Hello everyone. In this video we will talk about the left bundle branch block, which is obviously the second video in terms of the bundle branch blocks. And at the end of the video, please like the video, share the video, and also subscribe the channel and press the bell icon so that every next video can be available to you the moment it is uploaded. Thank you very much for watching the video. Again, when we are to talk about the left bundle branch block, like the right bundle branch block, we need to understand some of the basic stuff regarding the conduction system. And the impulse transmission starts from the sinoatrial node, goes through the interatrial or Bachmann tracts within the atrial muscles, causes them to depolarize, that generates a P wave, enters into the AV node, is delayed for a fraction of a second, enters into the bundle of His, and initially it goes into the septal branch, causes its depolarization of the septum, and then simultaneously enters into the right bundle branch and the left bundle branch. Left bundle branch has got two fascicles. One is the posterior fascicle and one is the anterior fascicle. So all these right and the left bundle branches, they have got Purkinje fibers at their ends, which are embedded into the ventricular muscle, and from here the impulse enters into the ventricular muscles and causes them to depolarize, which generates a QRS complex. And like the right bundle branch block, left bundle branch block is also represented on the ECG paper with the help of the chest lead. In case of the right bundle branch block, because it is located towards the right side of the chest, so the lead C1 was very important because C1 is located towards the right side of the chest. How we place the chest leads, let's revise it once more. This is the suprasternal notch, these are the clavicles, and this is right side, this is left side. If we come downwards from the suprasternal notch, this is the angle of Louis or manubrium sterni. Parallel to is the second intercostal space, which is used to anatomically localize the intercostal spaces. Then if we come downwards after the third, there is a fourth intercostal space. In the fourth intercostal space, in the right parasternal side, we place C1. On the left parasternal side, in the fourth intercostal space, on the left side, we place C2. Before we place C3, we'll have to place the C4 first. This is, we place it in the fifth intercostal space, in the mid clavicular line. This is the clavicle, this is the middle of it. We draw a line from coming downwards from here. There we place the C4. Do not make the apex or the nipple of the breast as an anatomical landmark to place the C4. Make it the mid clavicular line, fifth intercostal space. And in the middle of the C2 and C4, place the C3. Then fifth and sixth both are placed on the left side in the fifth intercostal space. C5 is placed in the anterior axillary line and C6 is placed in the mid axillary line. So if you try to focus here, C5 and C6, they are located towards the left side of this chest. They are located towards the left ventricle. They are located towards the left bundle branch. So if there is a problem with the left bundle branch, it will be more represented in the C5 or C6 rather than C1, C2, which were representing the left right bundle branch problem. So this is again a very important point to remember, that the chest leads will be representing the bundle branch block, and out of the 6 chest leads, C5 and C6, which are located towards the left side of the chest, will be more representative of the changes in the left bundle branch in case of the blocks. And talking about the normal morphology of the lead V5 or V6, which are located towards the left side of the chest, if we look at the morphology of the lead on the ECG paper, say this is V5 or V6, P will be because of the atrial depolarization. So this first positive deflection is because of the atrial depolarization. Now, though the QRS complex is because of the depolarization of the left ventricle, which is coming towards V5 or V6, but we can break it in 3 points. This Q wave, a first downward very small deflection, which is negatively deflected, is because of this septal depolarization, which is going away from V5 and V6. So this is known as the physiological Q wave. It has got its depth less than 1 or 1.5 millimeter, or less than 1 small box, or less than 1.5 small box. This is known as physiological Q wave, and it represents the initial septal depolarization going away from V5 or V6. Then the major muscle mass, its wave of depolarization is moving towards V5 and V6, that generates a very tall R wave. All those ventricular muscles which are located near this part, near the septum which separates the atria from the ventricle. This is a dead tissue. After striking here, the waves of depolarization will die down. But here the V5 and V6, they are located here. They look at the wave of depolarization of this part of the myocardium going away from it. That is why it makes a very small downward deflection, which is known as S wave. And T is obviously, we have so many times discussed that T wave is the because of the ventricular repolarization. So this is the normal morphology of the V5 or V6 when there is no left bundle branch block is present. Now let's take the example that there is a blockage. This green cross, it represents that there is a ischemia of the, for example, say left anterior descending artery, or there is any other problem which has caused the left bundle branch block. There is a block. Now the impulse will enter into the bundle of His, and from there it will go into the septal branch, will depolarize the septum, which will generate a first downward deflection of the Q wave. Then instead of going towards both of the bundle branches, it will only go towards the right bundle branch, because there is a blockage here. So when this myocardium of the right ventricle is depolarized, now in this case, when there is no depolarization of the left myocardium at the same time, wave of depolarization of the right myocardium will be going towards all of these leads. So even in the lead V5 and in V6, you will see a positive deflection as a result of the wave of depolarization of the right myocardium. In the normal stages, you will not see this thing happening because the left myocardium has got a huge muscle mass and a lot of wave of depolarization are simultaneously moving towards the V5 or V6. That generates its own positively deflected R wave. But here, this R wave is representing the positive deflections or wave of depolarization coming from the right myocardium or right ventricle. Now what will happen? No impulse will go down this track. There is a blockage over here. It's a left bundle branch block. Instead, what will happen, that once this positive deflection has been generated in the V5 or V6, this wave of depolarization is supposed to die down here. But instead, because these muscles of the left myocardium are still in the repolarized state, so through the muscles of the right myocardium or right ventricle, wave of depolarization enters from one muscle to the other, and it jumps from the right side to the left sided muscles. So the muscles of the left ventricle or the left sided myocardium, they are also depolarized in this way. Now it's taking longer than the usual time, which broadens the QRS complex. Normally the QRS complex is less than 3 small boxes or less than 0.12 second. But here, because of this transit through the ventricular muscle, which takes longer time as compared to its transit through the bundle branches, so there will be broadening. And when it is about to come down, when this wave of depolarization dies down for the lead V5 and V6 and it is coming down, by that time this wave of depolarization reaches on the left into the muscles of the left ventricle. So these muscles also start throwing the wave of depolarization towards V5 and V6 because they have been depolarized or stimulated by the impulse coming from the right myocardium or the right ventricle. This way, instead of going all the way down back to the isoelectric line, it goes high and it generates R prime or n other positively deflected wave, which represents the wave of depolarization of the left myocardium or left ventricle. Then when it goes towards the very last end of these muscles, it will generate S wave, and because of the ventricular muscles repolarization, there will be T wave. So let me explain once more. Wave of impulse transmits normally through both right and left branches, but here is a block in the left branch, so no wave will go there. It will first enter into the septal branch, will depolarize the septum, and V5 and V6 look at the septal depolarization going away from it. They generate a very small negatively deflected Q wave, which is a physiological Q wave. Then this wave of depolarization enters into the right bundle branch through the Purkinje fiber, enters into the ventricular muscle, causes them to depolarize. Now they are uncompeted depolarization because left myocardium is silent at this time. So this wave of depolarization is going not only towards the V1 and V2 but also towards V5 and V6, because there is no competition on the left side. So it generates a positively deflected R wave in V5 or V6. By the time it is about to die down, these impulses enter into the repolarized left myocardium, because there is no depolarization there. So these impulses find a way to enter into the left myocardial muscles. They jump from one muscle to the other muscle, and this is how they depolarize the muscles of the left ventricle or the left sided myocardium. And that wave of depolarization again starts going towards the V5 and V6, and instead of coming all the way down to the isoelectric line, after initial negative deflection, it goes back to create another positive deflection. This is how an M pattern or a notched R wave is generated in the V5 or V6. It does two things. One, it broadens the QRS complexes. Now the QRS complex is more than 3 small boxes or more than 0.12 second. And secondly, it generates a M pattern in the lead V5 or V6. So finally, we can conclude that the ECG criteria for the diagnosis of the left bundle branch block. This is a left bundle branch and here is a block. It can be because of the major ischemia. A new onset LBB is always taken equivalent to ST elevation MI. So, but the old left bundle branch block can be because of many other reasons. So, what is the ECG criteria for the diagnosis of left bundle branch block? The QRS will be broader than 3 small boxes or will be broader than 0.12 seconds, and there will be M pattern in either lead V5 or V6 or both of these chest leads. So this is how we can easily diagnose a case of left bundle branch block by looking at the ECG, and this is a very important diagnosis to understand.